Hey everybody, welcome back to the ECG channel. My name is Reid. Before we get started, go down into the description and download the PDF that is this document right here so that you can follow along with today's ECG, and feel free to subscribe and like this video if you want to support the channel so that we can grow and keep making these videos. So let's get started. So the first thing we do when we look at this ECG is I like to look at the forest, and the trees of the forest are my QRS complexes. So perhaps I'll come down to, say, this V5 rhythm strip, and I'll just kind of see we've got this narrow complex rhythm that seems to be tacking along quite regularly. As you can tell, that regular rhythm kind of goes through the whole ECG strip here. It appears at first glance that there are some P waves maybe in front of my QRSs, and the rate of this rhythm, it appears that if I start measuring this QRS, it would be 300, 150, 100, 75, 60, roughly 50 beats per minute. Okay, so we've got a bradycardia. So start working through this. We've got a bradycardia. And whenever we see a bradycardia, what do we think could be going on? Well, we know bradycardias are caused by either sinus bradycardia, it could be a junctional bradycardia, it could be a type of heart block. So there's plenty of reasons why we could have a slow rhythm here, and so we need to work through that as we are going through this ECG. So first thing I'm going to do is I'm going to evaluate what is my atria doing, and so let's evaluate the P waves. And so we do notice that there seems to be a P wave here. My P wave is upright in lead 1. It's upright in AVF. And so I would say that these P waves are sinus P waves. These are sinus P waves. Okay, and now let's look at, see, are those P waves conducting to my QRS complex by measuring my intervals? And the first interval I like to use is my PR interval. And if I look, say, maybe at this first complex here, my PR interval seems to be normal. My PR is less than 200 milliseconds, which is normal. And we know that PR intervals need to stay the same throughout the entire rhythm to call those normal and consistent. And so if I look down here maybe at V1, we can kind of evaluate that. We see we've got P that conducts to this QRS. It seems like P, QRS, but then PR intervals, notice this one right here is longer than the next one, which is, see, they're getting shorter and shorter until I don't really see a P wave there. And so, that makes me wonder, are these P waves conducting to the QRSs, right? Because remember, my PR interval should remain consistent. If my P waves, which are coming from the SA node, firing through the atria, that AV node is capturing that signal, delaying it for up to 200 milliseconds consistently, and then sending it down. And so if the PR interval here, like we see, is getting shorter, that tells me that the AV node is getting better, right? If the PR interval is shorter, AV node is doing this faster, but that's not how the AV node works. And so this makes me think that these P waves that we said that are conducting to this QRS are actually not conducting to the QRS. And so does make me concerned that maybe it's just trying to fool us. And if you look closer, what you'll notice, or what I notice at least, is that I've got the P waves. I'll see here I've got this P wave, but I've got a little squiggly right there, and then I've got my little P wave here, and then I've got another squiggly right there. And then it looks like at the beginning of this QRS, there's like a little P wave hump right there. You can see it just peeking out. And then you've got another P wave. And then the next P wave is probably buried in this QRS. You could actually see it in the QRS above right there. So what's happening is we actually have an atrial rate. These are all P waves that are quite fast. My atrial rate here, if you kind of march that out from, say, this P wave is 300, 150, 100, roughly 100 beats per minute is my atrial rate. And that tells me that what's going on here is my atria. If I erase this, my atria are beating at 100 beats per minute, so this is firing off and depolarizing the atria 100 times a minute, firing off 100 times per minute, but we said that the rate of the QRS is about 50. And so that means that only half of the time compared to the atria, the ventricles are beating. And so maybe this could be a 2-to-1 heart block, right? Where the AV node is only sending down every other beat. But what we would see with that is we would see a P wave that conducts to a QRS, and then the next QRS is not until 2 P waves later. And we don't see that, right? Because we don't see P waves in front of all these QRSs. And so, because of that, in the setting of a normal atrial rate that is faster than a normal ventricular rate in this case, this is diagnostic for a complete heart block or complete AV node block. Okay, so this person has evidence of complete heart block in the sense that the atria and the ventricles are dissociated from each other. They are not beating together. So, okay, so we've worked through the PR interval. We're not done yet. Let's look at our QRS. Our QRS is narrow. Okay, so we know that the QRS complex is narrow. My QRS is less than 120 milliseconds, which is good. And remember, in a complete heart block, where is this QRS rhythm coming from? The QRS rhythm is coming from somewhere within the junction, most likely, if it's narrow, right? Because remember, we said our AV node is blocked. And so there's no signal that can get down from the atria into the ventricles. So what happens is we've got this junction right here that is able to fire off and send signals down to the ventricles through the His-Purkinje system, and that's a junctional rhythm. So this narrow complex QRS is likely a very regular junctional rhythm at 50 beats per minute. Usually the AV junction beats from 40 to 60 beats per minute. So usually junctional is typically 40 to 60 beats per minute. It's usually slower than we expect the sinus node from 60 to 100. But let's evaluate the morphology of this junctional QRS. We see it's upright in lead 1, it's upright in AVF, so our QRS axis is normal. Let's look for a good R wave progression. We see that we don't have great R wave progression here in our septal, anterior septal leads throughout. I don't see great R waves, so not great R wave progression through the precordium. We'll kind of work through that in a little bit. Let's look at our QT interval. QT interval, I like to just measure midway between two R to Rs. And if you look at the midway point, my ST and T wave ends before then, so I have a normal QT. Happy with that. So the last thing we'll do is here we'll kind of look for these pathological Q waves and ST and T wave changes throughout. And first thing I notice is that we do have these pathological Q waves in the anterior, maybe septal, more septal leads, it appears, right? V1 and V2 predominantly. If you look at that initial deflection, there is no positive R wave. Remember, an R wave is if the initial deflection is up, this would be an R wave, but since the initial deflection is down, where we just go from flat to down, and it goes deep, these are pathological Q waves. So that tells me, since it's in the distribution of these septal leads, this person has had a prior septal infarct. That's a prior septal infarct. And also, if you look closely, those pathological Q waves are very deep, and we also have an extremely positive QRS here in these lateral leads. And you wonder, this person might have some risk factors for maybe some ventricular hypertrophy, and so maybe we just take a glance at that and see, and we count. I like to count for, to evaluate for left ventricular hypertrophy, I like to count the positive R wave in V5, and it will add it to the negative in V1. And so here we've got, say, we'll start from there, 5, 10, 15, 20, roughly 25, 26 to the top of that QRS, and then we'll add these two. So we've got 28 millimeters amplitude, and then the negative deflection here is going to be 5, 10, 15, 20, maybe 23 millimeters. So we add positive and negative 28 plus 23. That is equal to 51 millimeters. And that is greater than 35, which is LVH. So done that. Last thing we're going to do is look for some ST changes. I don't see any significant ST changes here that make me incredibly concerning. We see some depression in these lateral leads, but depression in the lateral leads in the setting of ventricular hypertrophy, especially ventricular hypertrophy of the lateral aspect of the ECG, which is left ventricular hypertrophy, that is just more to me of something called a strain pattern. And those are just ST and T wave strains that we see in the same leads, just like in right ventricular hypertrophy, you'll see some strain in those right ventricular leads. But here we see it in the left ventricular leads. So put this all together, and what do we get? We've got a sinus rhythm with a complete heart block. We have an adjunctional rhythm associated with that complete heart block. We've got a previous septal infarct. And we also have left ventricular hypertrophy with strain. So I hope this ECG helps. And if you have any questions, throw them in the comments. Feel free to subscribe to the channel. Have a great rest of your day.